Welcome to the CAA 2022 webinar series. Today's webinar is Pre-Hospital Management of Paediatric TBI and the Impact of Dealing with Traumatic Paediatric Emergencies, presented by Dr. Amanda Humphries-Ventura and proudly supported by Zoll. Thanks for joining us and please enjoy.
Welcome to the Council of Ambulance Authorities webinar series. I'm David Waters, Chief Executive of the Council, and I will be your host today. Today we will discuss pre-hospital management of paediatric traumatic brain injury and the impact on clinicians of dealing with traumatic paediatric emergencies. Many thanks to Zoll for sponsoring this webinar. Firstly, today's webinar will discuss the general principles of traumatic brain injury with an emphasis on how it affects children. Secondly, with traumatic paediatric cases being a common stressor facing healthcare providers, we'll learn about the signs to watch out for in ourselves and our colleagues and the strategies for preventing burnout and other effects of prolonged and repeated exposure to trauma. Our speaker today is Dr. Amanda Humphries-Ventura. Amanda has developed a special interest in traumatic cardiac arrest and events and provider health and wellness. Amanda is an assistant professor in emergency medicine at the University of Texas. As a transport physician and medical director, she has extensive experience both in fixed wing, rotary and ground critical care transports. She completed her emergency medicine residency at the University of Cincinnati Air Care, where she served as a flight physician and resident assistant medical director. She has also held an EMS fellowship at the University of New Mexico, where she served as a flight physician. Dr. Humphries-Ventura has published extensively on trauma and emergency medicine, so please join me in welcoming her to our webinar today. Welcome, Amanda, and thank you.
Good morning, everybody. My name is Amanda Humphries, and I'm an assistant professor at the University of Texas in Houston, Texas. And today we're going to start out by talking about pediatric TBI. This lecture is funded and an honorarium has been provided by Zoll, but any opinions in this lecture are my own and do not necessarily reflect the opinions of Zoll. So why are we discussing this? Well, 2% of the population are living with such severe long-term effects from a TBI that they require assistance with activities of daily living. In fact, worldwide, TBI is the leading cause of death and disability in children. Why is it so prevalent in children? Well, I would venture to guess that part of the reason is because they are all head. The younger the child, the higher the proportion of head compared to the rest of the body. This graph is very telling. You can see that while total incidence of TBI and ED visits for TBI are uptrending, hospitalizations and death remain the same. The fact that death remains the same while incidence is uptrending tells me that there are more and more people that are living with the long-term effects of TBI. Remember, this is the leading cause of disability in children who have many life years left. The leading cause of TBI varies by age. In the very young and very old, the leading cause are falls. In the young to middle adult years, the primary cause of TBI is car accidents. I want to highlight a few things about the GCS, especially as it relates to children. We all know that GCS is a bit of an inexact science. It does not give any information about why the patient has an altered mental status, and a patient may be scored slightly differently from person to person. When I'm teaching GCS, I emphasize that it is most useful when the same provider scores a patient repeatedly over time. Like most numbers, trends are more useful than an isolated value. Now, with respect to children, there are adjustments based on what a child of a given age is expected to be able to do. This adds another layer of complexity. In adults, we already cannot use the GCS to determine why someone is altered. It could be due to hypoglycemia, intoxication, or a whole host of other things. But in kids, now we have to know their age, which can actually be challenging in a chaotic trauma scene. And we are also making the assumption that the child is developing normally for their age. GCS is still a useful tool, but we must keep in mind the limitations. To facilitate more discussion about the care of TBI patients, I want to discuss the EPIC trial. EPIC, or Excellence in Pre-Hospital Injury Care, was an 8-year statewide study of pre-hospital care in the state of Arizona, a state with about 7.1 million people. The investigators of this study were based out of the University of Arizona, and they assessed the effect of standardized EMS education on compliance with expert guidelines for the pre-hospital care of patients with known or suspected TBI. The primary aim of the EPIC trial was to evaluate the impact of implementing pre-existing EMS TBI guidelines throughout EMS agencies in the state of Arizona through implementation of standardized protocols and education. More than 130 agencies participated, and in fact, 93% of TBIs that occurred in the state of Arizona during the study period were carried out by EPIC agencies. They trained over 11,000 providers and took care of about 22,000 patients, including nearly 3,000 pediatric patients. The study compared patient outcomes from phase 1, the baseline, which was primarily retrospective data collected on TBI patients cared for by participating agencies. During phase 2, agencies had standardized protocol implementation and provider education. And in phase 3, the post-intervention phase, they again collected data on patients cared for by participating agencies. Data was abstracted from over 36,000 EMS patient care reports and linked to in-hospital data and patient outcomes through the Arizona State Trauma Registry. They had a remarkable rate of successful linkage of pre-hospital and in-hospital data of 98.7%. Patients were included based on anatomic and clinical injury severity. Clinical severity were patients judged to have moderate, severe, or critical head injuries. Of note, this was not dependent on GCS. As we mentioned before, GCS is not specific for brain injury, and thus not a good inclusion criteria. The study protocol was extensive, but I want to focus on the protocol that was used for training providers and setting expectations for how patients were cared for. The first area of emphasis was hypoxia. Providers were instructed to prevent, recognize, and urgently treat any hypoxia, defined as an O2 saturation less than 90%. All patients were to get non-rebreather with 15 liters a minute, and if this was not sufficient to maintain saturations above 90, they were to initiate bag valve mask ventilations at age-appropriate rates. There was an emphasis on limiting intubation to specific circumstances. It was only to be used when there was persistent hypoxia with BVM use, high risk of aspiration, or logistical concerns such as air transport or long ground transport times. The next area of emphasis was hypotension. Providers were again taught to prevent, recognize, and treat this condition, with the threshold for hypotension being a systolic of 90 in adults and age appropriate in children. The protocol called for administration of IV fluid if the systolic was approaching the lower limit or if it was dropping rapidly at any value. Initial dosing was 1 liter of IV fluid in adults, age appropriate in children, with repeat boluses of 500 mLs to maintain a systolic at or above the target. The third and final point of major emphasis in this trial was strict avoidance and immediate correction of any hyperventilation. Providers were trained to provide respirations at the rates listed on the slide with a target and title of 35 to 45 millimeters of mercury. Now for the results. The trial enrolled nearly 22,000 individual patients, all of whom had moderate, severe, or critical TBI. You can see from the slide that these categories were defined by head region severity score, and the majority of patients, or 70%, were in the severe category. The data on the pre- and post-intervention groups is immediately interesting. Despite the fact that the post-intervention group was significantly sicker and more likely to be categorized as severe TBI compared to the pre-intervention group, they had a lower rate of intubation and a lower rate of hypoxia on hospital arrival. Those patients that did get intubated were less likely to be hyperventilated on arrival, and the post-intervention group was also more likely to have received IV fluid if they were hypotensive or near hypotensive. The primary analysis quantified survival to hospital arrival and survival to hospital discharge. Investigators found an increase in survival to hospital arrival with an adjusted odds ratio of 1.7. However, there was not an increase in survival to hospital discharge. Even though survival to discharge could be considered a more patient-centered outcome, survival to hospital arrival is much more proximal to EMS care and does not have all of the confounding factors of the care received in the hospital. So I do feel that it's still a significant finding. For the secondary analysis, outcomes were assessed based on head injury severity. I find this data particularly interesting because when you look at the severe category alone, there is a significant improvement in survival to hospital discharge. Post-implementation severe injuries were 2 times more likely to survive compared to the pre-intervention group. The prevailing theory as to why this is that this is the group that we have the ability to affect. Perhaps those with moderate injury are going to survive regardless, and those with critical injury are going to die regardless. But the severe group provided the greatest opportunity to influence their outcomes. We continue to see a benefit in the severe group when we look at the subset of the severe group requiring positive pressure ventilation. They had a 3.5-time increase in survival to hospital discharge compared to their pre-intervention counterparts. In conclusion, statewide education and implementation of standardized TBI guidelines were not associated with improved survival across the entire spectrum. However, survival doubled among patients with a severe injury and tripled in patients with severe injury requiring positive pressure ventilation. Implementation was also associated with improvement in survival to hospital admission across the entire spectrum studied. Now, what about kids specifically? Kids were included in the overall 22,000 patients that we just talked about, but there was also a sub-analysis of EPIC known as EPIC for Kids that looked at only pediatric data, and they found that the data for kids alone mirrored the overall data almost perfectly. Again, there was improvement in survival to hospital admission, but only in the severe group for survival to hospital discharge. Again, just like adults, kids were less likely to be intubated in the post-intervention group, even though they had an overall higher injury severity. So more of the patients that required positive pressure ventilation were treated with BVM ventilation. Again, similar to adults, there was less hypoxia on hospital arrival and fewer intubated patients were hyperventilated. One interesting finding that was unique to kids is that improved patient survival with guideline intervention increased with decreasing age. This is thought to be related to increasing neuroplasticity with younger age. So why are we talking about this study? We're talking about this study because, at least in the United States, there's a clear need for standardization. But perhaps even more importantly, they found that high-quality EMS care has the potential to improve patient survival, especially in sicker patients, and thus emphasize that what we teach and practice in the pre-hospital environment matters. Now, let's discuss this in a little more detail. Not only does what we do matter, but it's the simple things that seem to matter the most. A single episode of hypotension doubles mortality, and a single episode of hypoxia tripled mortality in the group with severe TBIs. This is why I love teaching TBI. The critical actions are the simple things. The care of TBI illustrates a critical principle of medicine, that it is often the basics that save lives. All too often, we get caught up in fancy things like new intubation techniques and the latest drugs. The only things that are proven to matter are still good old-fashioned oxygenation and blood pressure. This graph shows that the effect of hypoxia and hypotension are additive. Across the x-axis, you can see we have overall mortality, then mortality broken down by presence or absence of hypoxia and hypotension. A patient with neither of the two has a mortality of about 5%. Presence of one or the other places risk of mortality around 20 to 25%, and presence of both increases mortality to nearly 50%. Now let's take a look at each of these in turn. Not only is the occurrence of hypotension deadly, but it's also common. About a third of severe TBI patients will have at least one hypotensive episode. I also want to emphasize that these episodes of hypoxia and hypotension are from first medical contact. I emphasize this over and over when I speak to pre-hospital providers because I want to drive home the point that every single member of the pre-hospital team matters. The clock does not start when the senior paramedic arrives on scene. The clock starts when the very first person with medical training and certification arrives on scene. I found over the years that emphasizing the critical importance of contributions from all members of the team is extremely helpful in engaging providers of all skill and certification levels. The graph on the right-hand side of this slide shows that yes, one episode of hypotension increases mortality, But mortality also continues to rise with repeat episodes of hypotension, from about a 20% mortality rate with one episode to mortality rates as high as 90% for 3 or more episodes. Moving on to hypoxia, this is even more prevalent than hypotension in trauma patients, with 50% of intubated patients and 55% of severe TBI patients having at least one episode of pre-hospital hypoxia. Just a reminder that hypoxia is defined as less than 90% SpO2. In talking about hypoxia, it's critical to point out the key here is avoiding hypoxia, not necessarily securing the airway. Intubation has been considered the holy grail of airway management, but the newest data suggests that it may not always be in the patient's best interest. Recall that in the post-intervention group, there was improvement in mortality for severely injured patients, decreased episodes of hypoxia, and decreased rates of intubation. This was a meta-analysis that looked at pre-hospital intubation and TBI. They found that providers with less experience in intubation had increased rates of patient mortality with intubation. Given that intubation opportunities are dropping worldwide because of the wide acceptance of supraglottic airways, this is critical data to keep in mind. This depicts that graphically, the relationship between pre-hospital intubation and mortality. You can see in the top cohort, which are limited experience intubators, there is a clear mortality benefit to withholding pre-hospital intubation. The lower cohort are extensive experience intubators, and while that data does trend in the direction of intubation, it is not significant, and the combined data trends toward withholding intubation. Why is this? I suspect that peri-intubation hypoxia and hypotension play a role in this, as these events are common in the pre-hospital intubating environment. We teach our trainees in the hospital to ensure that they are maximizing their chance of success on their first airway attempt by creating an ideal environment. Intubating in the pre-hospital setting is far from ideal. In addition to the patient's injury causing hypotension and hypoxia, there is the effect of induction agents on blood pressure and prolonged intubation attempts on O2 saturation. Remember in the EPIC study, where survival improved after intubation, they found decreased rates of intubation and increased rates of BVM-only management of the airway. This is a significant paradigm shift from the way that I was trained and the way that I initially taught airway management. I taught that the endotracheal intubation is the only truly secure airway, and that it is preferred in seriously injured patients. As I was putting this material together, I could recall specific patients that I took care of in the pre-hospital environment that could have been managed by less invasive means that I intubated with resulting hypoxia and hypotension. This is one of the biggest changes that I've made in my education for pre-hospital providers, focusing on high-quality BVM and supraglottic airway placement and de-emphasizing intubation, especially in TBI patients. The third key patient care component of the EPIC results demonstrates another key principle of medicine. Most of the things that we taught 10 years ago, we now know are wrong. Many of you may remember being taught to hyperventilate all head injuries. I know that I remember learning this in medical school, and in the beginning of my career teaching pre-hospital providers, I certainly taught this incorrectly. It seemed like a good idea to cause vasoconstriction and decrease volume inside the skull to prevent herniation. However, we subsequently realized just how critical it is to deliver oxygen to the injured tissue, which we were actively inhibiting by hyperventilation. The other thing to keep in mind is that hyperventilation also leads to decreased coronary blood flow. And if coronary perfusion pressure is low, BP will decrease. So hyperventilation is actively causing the hypotension and hypoxia that we're working so hard to prevent. Explaining the pathophysiology behind hyperventilation is why it is actually bad, and why it is actually bad in head injuries brings up another point about teaching and training pre-hospital providers. It's critical to provide the why behind what we are teaching. I have found that the paramedics and other pre-hospital providers that I teach crave a deeper understanding of why they are doing what they are doing, and providing this type of education not only leads to better understanding, but also shows that you care about the growth and development of the people that you're leading. Hyperventilation is also independently associated with at least a doubling of mortality. You'll note that I put an asterisk next to the end tidal value. The goal is normal, but that may not be possible in polytrauma because polytrauma, especially with a hemorrhagic component, will quickly lead to a shock state. The poor perfusion will lead to low end-tidal, in which case the target is maintain initial CO2 value. This is a reason that everyone should have end-tidal applied with their initial vital signs. This graph comes from a study that compared intubated and non-intubated patients with their CO2 value on arrival to the hospital. The darker bars represent intubated patients, and the lighter gray represents non-intubated patients. The red brackets denote the target end-tidal range, and you can see that the intubated patients are much more likely to fall below the target range in the territory of hyperventilation. This tells us that iatric hyperventilation is still a significant problem with pre-hospital TBI care. So intubation is associated with hyperventilation. I personally always thought that the data showing increased mortality with intubation in TBI patients was related to peri-intubation hypoxia and hypotension. But now this data suggests that it's also associated with hyperventilation. Intubation seems to be associated with all three of the major killers in TBI. All of this is why the person with the BVM is probably the most important person on the team. I will again stop here when I'm teaching pre-hospital providers and remind them how important the basics are. It's often an EMT basic and not a paramedic that is bagging the patient. And I use everything we just talked about to emphasize just how critical they are to the team. Why are so much time on all these details? Well, brain injury is a two-step process. These photos depict the primary injury, moment of impact, nothing we can do about it. However, secondary injury happens at some time point later. Data now suggests that it is the most likely to happen in the seconds to minutes following primary injury, which is why EMS and ED care is so critical. In stroke, it's called the penumbra. It's the tissue that is in jeopardy. Perhaps it has collateral blood flow that is partially sustaining it, but insults such as ischemia, byproducts of the inflammatory cascade, and systemic insults that we have discussed, hypoxia, hypotension, hyperventilation, all damage this tissue at risk, and without intervention, it will eventually die, just as the tissue affected by the primary injury did. Now remember, one of the initial aims of the study was to see if there was an effect by providing standardized education. The answer is a resounding yes. In fact, though the interim analysis data did not meet the criteria for stopping the study early, they ultimately found that there were better survival statistics at the interim analysis closer to the education intervention than the final analysis. This tells me that the education component of the initiative worked, and it also emphasizes the need for frequent refresher education. We're getting close to wrapping things up, but before we do, it bears repeating that the message is very simple. Avoid hypoxia, hypotension, and hyperventilation. In conclusion, avoid those 3 H-bombs. Each of these at least doubles mortality in severely injured patients. Pre-hospital providers may be uniquely situated to prevent secondary injury, as we are discovering this process happens soon after the primary injury. Emphasize to providers that this is time sensitive, just like strokes. Time is brain, with the difference being that we offer much of the definitive therapy in the field by improving oxygen, blood pressure, and maintaining normoventilation. Finally, pre-hospital provider education should emphasize the importance of the basics and the need for best efforts from all levels of provider, not just the senior medic at the scene. Pre-hospital providers also benefit from education on pathophysiology and the other whys behind what we do. All right. Now I'd like to take a few moments to focus on provider wellness. Why address this? Well, we deal with hard things. The only way to preserve yourself and be at your best for your patients is to allow yourself time to process. The data that we're going to look at shows us that these hard things are taking a toll on us, and we need to face them head on for the sake of our well-being and the well-being of our colleagues. This data from an article about post-traumatic stress and growth in firefighters first surveyed firefighters to determine what types of stress they have been exposed to. This partial list shows many of the items and the percentage of firefighters surveyed that said they had this experience. Many of the items on the list are things that we've grown accustomed to. It's worth pausing for a moment and recognizing that things like treating a seriously injured child, body retrieval, and the real possibility of duty-related serious injury or assault while on duty are not normal human experiences. As I'm sure that many of you have, I've had my own share of traumatic encounters, which led me to investigate how conditions like PTSD develop. The American Association for Physician Leadership proposed these 5 risk factors for PTSD in physicians. And I would propose that several of these also apply to any provider in the emergency department or pre-hospital arena. Like I said, I got interested in these statistics due to personal experience, and the sparse data on this subject suggests that I am far from alone in this. Data from a meta-analysis of 45 years of information indicate that 10% of all Coma first responders meet diagnostic criteria for PTSD, increase from the expected 7% of the general population. Interestingly, first responders categorized as ambulance personnel have increased rate of PTSD compared to police and fire. Some studies suggest rates of PTSD in EMS personnel closer to 20%. And these numbers are using strict diagnostic criteria. A full quarter or 1 in 4 EMS staff were found to have characteristics of PTSD, anxiety, depression, or general psychologic distress in another study. Why does this matter? Not only does post-traumatic stress decrease quality of life, but it's also been consistently shown to increase mortality in civilians and first responders. A study of 64,000 registry enrollees showed that those with PTSD had increased cardiovascular and all-cause mortality. These numbers showing our increased risk of serious mental health consequences suggest that one of my personal favorite defense mechanisms, I am different from my patients, is not consistent with the evidence. We're not that different, and sometimes a whole lot worse off than our patients. Unfortunately, PTSD is not the only thing that we have to contend with. The data throughout the helping professions regarding alcohol use and misuse is cause for alarm. The data throughout the helping professions regarding alcohol use and misuse is cause for alarm. The first thing to note is that there just isn't a lot of data. The study on psychiatric comorbidity in physicians in substance abuse treatment looks at data from the 80s and 90s. I would never present data from the 80s if I was talking about a medical intervention, but in terms of physician mental health, it's about all that we have. And the situation is not much better in EMS. The bulk of the data on first responders focuses almost entirely on firefighters and police, with very little data on EMS providers beyond the first responder and EMT role that firefighters play. However, if we take the firefighter data and extrapolate it to EMS, it suggests that there is a strong relationship between on-the-job stress and substance use. Study after study showed a strong positive relationship between PTSD and other psychiatric comorbidities and substance use, with post-traumatic stress and increasing symptom severity associated with increasing rates of alcohol use, increasing rates of binge drinking, and increasing rates of risk-taking behaviors such as driving while intoxicated. Most interestingly, one study showed increased likelihood to drink and drive among higher-ranking firefighters, which suggests that the argument of you know better than this is not effective. The data not only suggests that those of us that work in medicine are at high risk for substance abuse, but it raises concern that we may not see it coming. One study showed that 76% of physicians that met criteria for substance abuse did not see any problem with their substance use patterns. Finally, I want to point out that women are at particularly high risk. Not only is our rate of alcohol abuse higher, data suggests about 20% of female physicians abuse alcohol and 40% of female firefighters abuse alcohol. But a study of physicians enrolled in state monitoring programs showed that female physicians were also at higher risk for psychiatric comorbidities, including more likely to report suicidal thoughts and attempts. 50% of female physicians being monitored for substance use reported a history of suicidal ideation. 10% reported active suicidal ideation, and 20% reported a previous suicide attempt. A similar study of female firefighters showed a 30% lifetime rate of suicidal ideation, with previous diagnoses of depression, PTSD, and being single, all producing increased risk. Finally, there is the humbling data on the ultimate downstream effect of struggles with mental health. In the US alone, 400 physicians die by suicide every year. How does that compare to the general population or other professions? Compared to the general population, male physicians have a relative risk of 3.4 to die by suicide. Female physicians a relative risk of 5.7. Additionally, many experts believe that this estimate is overly conservative because of an effort by colleagues to attribute death to other causes whenever possible, both due to stigma and the ability of surviving loved ones to collect insurance. What about in our pre-hospital role? A comprehensive review of the data available on suicide in first responders of all types again reported that the vast majority of the data is on police. There's an increasing amount of data on firefighters and a remarkably small amount of data on paramedics and EMTs. They did, however, find that firefighters that were in a department that also responded to medical calls were 6 times more likely to have suicidal ideation compared to firefighters that only responded to fire. This suggests that the things that we see do increase our risk. Women are at a remarkably high risk, with about 25% of all firefighters surveyed admitting to suicidal ideation at some point in their lifetime, and this increases to 30% for females. How did we get here? I think the shame has a lot to do with it. Again, we have to extrapolate data from other health professions to medical first responders because of the lack of data. But a recent survey showed that 40% of physicians reported that they were reluctant to seek mental health care because of fear of licensing concerns. This data looked specifically at suicidal ideation and attempt in first responders. They again saw a staggering increase in both suicide ideation and suicide attempts compared to the general population. The blue bars represent first responders, while the orange bars represent the general population. Of the over 4,000 medics surveyed, 85% had been exposed to critical stress, 37% contemplated suicide at some point in their career, and a little over 6% attempted suicide. Now, what about pediatrics specifically? This article specifically looked at first responder stress and pediatric calls. It was a qualitative study that conducted focus groups with first responders of various levels of training and years of experience to determine why pediatric calls are difficult, how providers prepare for them, how they cope with especially difficult calls, and both resources and support that are currently utilized and those that they would like more of. The reasons that pediatric calls are difficult are relatively intuitive. We as a society place special social value on children. The circumstances of illness or injury highlight their vulnerability, and when they do have serious consequences, it represents more quality life years lost. Pediatric patients tend to be more clinically challenging, either because of smaller equipment and less familiar drug doses, a tendency towards higher acuity calls, or unfamiliar and rare illness processes. There's also the issue of the parent caregiver as a secondary patient, and finally, the risk of identifying with the patient or their family. Perhaps the child is the same age as yours, or you cannot help but think about how you would react in a similar situation. The themes for how providers prepare for these situations are actually quite simple. Many stated that they look up and review possible clinical scenarios, protocols, and drug dosages while en route, and this goes hand in hand with the request for more frequent pediatric training. Providers also discussed using reframing, which was described as focusing energy back on the task at hand and using emotions to fuel focusing effort on the patient. Coping mechanisms described fell into both constructive and destructive categories. Constructive coping included sharing with other people and working towards achieving work-life balance. Using sarcasm and humor does not address the underlying need to process events, but can be helpful when not in a safe environment to process. Engaging in activities away from work could be both constructive and destructive, but one of the activities frequently listed was drinking. As we discussed earlier, this is a common problem in our line of work. Social support within the department was the most common currently utilized strategy for coping. Some participants also described talking with a department chaplain or personal spiritual advisor. Critical incident stress debriefing, a process that has both advocates and opponents, was described as helpful and hurtful by different participants. Some felt that it led to closure and the ability to move forward. Others felt that it was another traumatic event to relive the initial event in a group. Specific to pediatric calls, providers identified more pediatric training, highly visible marking on pediatric supplies and storage areas, improved patient outcome follow-up from receiving facilities, as well as the ability to take an apparatus out of service for a period to recover from distressing calls as ways to potentially decrease ill effects of these distressing calls. This is another data set that looked at factors associated with post-traumatic growth versus post-traumatic stress. We cannot affect all of these factors, such as the increased likelihood to see post-traumatic growth in females, but many of these are within our ability to affect change. As I mentioned before, there are proponents and opponents to critical incident stress debriefing. But this data set showed that it was associated with experiencing post-traumatic growth instead of post-traumatic stress. I would challenge those using this technique to proceed carefully and keep in mind best practices, such as ensuring that it happened shortly after the event, making it optional, and ensuring that it's very clear that information shared during the session will not be used in any sort of disciplinary proceedings. Social support also played a significant role in the experience of stress versus growth. This is the informal expressing care and concern for one another and comes up over and over in the data as protective against PTSD and other psychological consequences. The care of injured and ill pediatric patients is just one category of the human tragedies that we have the privilege of caring for day in and day out. My challenge to you is to go back to your job and look at these factors, where there can be change and improvement such that you and your colleagues can remain as ready as possible to put your best foot forward whenever the opportunity arises to provide life-saving care.
Hi, Amanda. Thanks so much for taking the time out to share your experience and knowledge with our attendees today. Fascinating presentation, lots of really amazing and useful information. I do have a couple of questions from our attendees, so I'm just going to run through those with you, and then a couple from myself. First question I've got is, do you have any thoughts on sedation for supraglottic airway placement in pediatric TBIs?
That's a great question. And first of all, I just want to say thank you so much for having me. I really appreciate the opportunity to get to talk about the information in the webinar. Sedation for pediatric supraglottics. It's funny that you bring that up. I actually have spent some time working in Albuquerque, New Mexico. I did my fellowship there. And one of our faculty there, Darren Brody, is a huge advocate for what he refers to as RSA, the rapid sequence airway, as opposed to RSI, rapid sequence intubation. And he actually has some cases where he's used rapid sequence induction and paralytics specifically for pediatric supraglottics. And we've seen a lot of really good outcomes with those. I'm a huge proponent of supraglottics in general. I think that I think it, it probably came through in the presentation, but just to reiterate how big a fan I am of them in the right patient population. But in terms of the medications involved, absolutely. I think we need to have less distinction between intubation and supraglottics. So all of the things that we talk about in terms of intubation, like, making sure that your first attempt is your best attempt, setting yourself up for success, all of that applies to supraglottics as well.
Great. Awesome. I'm kind of linked to that question to a degree. My second question for you is really a better understanding of where the definition of hypoxia at 90% SATs comes from. I think our paramedics have typically been taught 93%, and they wondered if that was specific to TBI in kids, the 90%.
Honestly, it's just a number that has been used from study to study in the literature. It's one of those things that has become convention in the literature. Honestly, me personally, I kind of prefer a little bit higher. I prefer the 93, 94% threshold. Reason being is once you're at 90, you're getting really close to that part of the cliff that becomes much steeper and drops off much faster. And so it's just a literature convention. I would not change my practice pattern based on that. The big point to drive home is how important it is to avoid hypoxia. But keeping a little bit higher threshold, 93, 94, I think is only to the patient's benefit.
And kind of staying on the education theme regarding paramedics, can you tell us a little bit about the type of education pre-hospital providers get in the States in regards to traumatic brain injury in pediatrics? I'm always interested to see the level of focus different programs put on particular conditions.
In the US, I think our biggest issue is that it's not standardized. One of the things that I hear from paramedics over and over and over is more pediatric education. I think that we tend to focus on adults, with the rationale being that we see more adults, and that is true. But I worry personally that pediatrics become a bit of an afterthought. I've seen a lot of paramedic education where there is the whole presentation on a condition, let's say abdominal pain. I'm just kind of picking a chief complaint out of the air. We talk about all of the adult conditions. We talk about how adults present, on and so forth. And then there's a couple slides at the end about how pediatrics are different. And I think that has been the case in TBI as well. That was one of the things that I think the EPIC trial did so well, is there was a whole arm of the trial, EPIC for Kids, that looked specifically at how, are pediatrics different? What things look different? And so I would say it's probably an area of education in the US that's lacking somewhat. I think our paramedic education in general tends to be a little variable, especially regionally. And so those are kind of my general thoughts on that.
Yeah, I think it's pretty much the same here in Australasia. We're really good at focusing on the really little neonates and really little kids and adults, and miss out that bit in the middle, kind of the 3-year-old to the 12-year-old kind of gets a bit forgotten. And
exactly.
And we've been having some really interesting conversations around that in Australia and New Zealand. So very topical at the moment. As you would know, Australia and New Zealand are quite physical countries when it comes to sports. We start our children off really young in kind of contact sports such as rugby and horse riding. Do you see high numbers of TBIs from contact sports?
It's funny that you brought up rugby. I actually played rugby in high school. So I have a little bit of a soft spot for those type of sports. I had a wonderful time. But yes, we do. I would say the biggest, the largest cause of pediatric TBI, we kind of talked about falls and car accidents, but in terms of recreational activities, for us, it's American football. That's something where we start the kids out young. And even with the protective gear, we see a relatively high rate of TBI. And I'm interested to hear what it's like there, but our biggest hurdle there is encouraging players, parents, and coaches to allow for the appropriate time for healing. We always teach that concussions need to be symptom-free before they return to play. But return to play guidelines are our biggest challenge here.
It's the same here. I think we're really good at doing that for professionals. I think we're not as good at managing concussion and TBI in probably our young adolescents who play college rugby, etc. We're getting better. We're certainly doing a lot of research into it. We now have mouth guards with built-in concussion sensors. So we are doing some studies in regards to that in Australia and New Zealand. So look, we're on the right road. It's a lot of work to do though.
Yes. Yeah, no, and this is the population, this is the patient group that has the most to lose, right? They're the ones whose brains are still developing. And I mean, our frontal lobes are developing up until about, age 25, but these adolescents, their brains are expanding leaps and bounds. And so they really are the most susceptible to potential downstream effect.
How did the management of pediatric TBIs get affected by COVID? And were there any lessons that you took out of that?
I think in the initial days of COVID, we saw a decline. I think just like everyone everywhere, we saw a decline in a lot of the injuries that come from our activities, be it daily activities like driving or recreational activities like sports, because none of that was happening. I think the biggest challenge in patient care during COVID for us, and I'm sure it was similar in Australasia, is the volume of patients that we had to care for, and trying to keep hospitals a place of healing. Especially when kids came in, there was a huge push to get them out the door as fast as possible to keep them from potentially getting sick in the hospital, which is, completely reasonable. But I think that was probably, in my mind, the biggest barrier to care was just trying to keep people away from us. And then, and that also goes in terms of, ED disposition, discharge versus admission. There was a huge push to minimize admissions, both because of volume issues and because of, preventing exposure issues.
Yeah, absolutely. So similar here. The other thing I'm interested to hear your views on is obviously in New Zealand, Australia, we went into a number of lockdowns. I'm not sure if you had many lockdowns in Houston, but certainly we had all our children at home, learning at home, parents as teachers, locked up in a house for days and weeks on end. Did you see an increase in abusive head trauma because we had a massive increase in domestic violence during that period? Just wondered if it kind of flowed over and affected the pediatric community.
Right. I'm not yet aware of any data that's coming out on that. I'm sure that it's out there, and I'm sure that we'll be seeing it. Me personally, and kind of anecdotally among, my partners that I practice with, there was definitely the increase in domestic violence. I didn't really see a huge uptick in pediatric downstream effects of that, but I wouldn't be surprised if there was an increase, and we may have just not appreciated it because we were so inundated with COVID.
And there was a couple of takeaways I took from your presentation that will stay with me for life, I'm sure. One of those was the basics save lives, and that is so true. And we do forget that. It's never, we can't repeat that too often, I think. The other one was avoiding the H-bomb, which I found particularly useful, H-bombs. And look, thank you for those views and comments, because they helped me retain the content of your webinar.
I'm so glad you brought that up. That's one of the things that I love about TBI and teaching TBI, is that it drills home what I really think is one of the great principles of medicine, and it's the basics that matter. And then you mentioned the H-bombs, hypoxia, hypotension, hyperventilation. Just a quick plug for what may be coming down the pipe. I think there's another H-bomb coming, and that's hypothermia. There was a very recent article that came out from the EPIC investigators, and time didn't allow for me to add it into the presentation, but it looked at initial core temperature on arrival to the emergency department, and it saw that there is a sweet spot that shows that really hyper and hypothermia are detrimental. Hypothermia seems to be even more detrimental, but now I think not only are we going to be talking about maintaining, normal ventilation, normal O2 sats, normal blood pressure, but normal temperature as well.
We will make sure the team hears about that. Keep an eye on it. You rounded out your presentation talking about the mental health and well-being of responders.
That's something that's very much front of mind for us in Australasia. We have spent the last, would say it's 5 to 6 years trying to improve the support for our first responders in that space. We know that particularly our paramedic workforce do get exposed to a lot of repeated trauma. And so we've got lots of wraparound services now. I don't think we could ever have enough. We certainly have a very extensive peer support program. We've taken a national approach. So we have a national strategy about the mental health and welfare of our first responder workforce. So we bring all our ambulance services together 2 or 3 times a year just to talk about that and how we can continue to support and improve resilience. And when trauma starts to affect our teams, how we can manage that better. So we're kind of fortunate in Australasia that we have 8 large ambulance services, unlike the States, which has many, many, many small ones. So we now have the ability to have psychologists, psychiatrists, lots of other mental health experts within the team. So we have internal mental health and wellness support as well as the external systems that you would typically see. So look, it's a very important topic, and we do need to keep talking about it. We do kind of have a lot of mental health and resilience champions now in our sector, which is great. And so thank you for covering that off, because we think about it in regards to a lot of the interactions we have with patients, but it's the pediatric ones that often are the most difficult to bounce back from in our experience. So.
No, I absolutely agree. A couple of the things that you touched on that I just wanted to re-emphasize, you mentioned specifically paramedics, and of all of the kind of different data and statistics that I talked about, I think that was the one that hit me the hardest. And I think just bears repeating is that paramedics are 6 times more likely to have ill effects than firefighters. And that's not to take away from what firefighters see and experience, but I think it just goes to show just how difficult some of the things that we see are. And it reminds me of the need to respect that and to take time for that. But yeah, it's an area that I don't think there will ever be too much focus on or too much, work into, because like you said, it is the effects can be devastating. And one of the other things that I just wanted to put a little plug in for is obviously this talk focused on pediatrics. And it is absolutely true that pediatric calls tend to carry more of these types of effects. But I would just encourage anyone listening to recognize that what I have found is you don't get to pick the call that is the one that does it for you. It may be a big dramatic call with, lots of news coverage and so on and so forth, but it may be the kid that actually wasn't that sick, but just looked like your kid, and the parent reminded you of yourself. And that the need to work through that is the same as the need to work through that big dramatic call with all of the news coverage and all of those types of things. And so that would be one of the things that I didn't really get to touch on that I would encourage everyone to remember, is that you don't get to pick which one, and it doesn't matter. It's irrelevant which call it is. It deserves all of the same attention.
Great message. Thank you. And a good message to wrap up on. So just from the CAA, thank you, Amanda, for taking the time. We really appreciate your presentation and the Q&A session. Hopefully we'll see you down in Australasia at some point in the future. It would be great.
I would love that.
See you down there again.
I would love that. It's been a few years since I've been there. I would love to come back.
Very cool. And of course, thank you to our sponsors, Zoll, for making this possible. And for all our watchers, our next webinar is the 28th of Feb. We've got Professor Richard Lyon from the UK talking to us about using data to improve pre-hospital care. So look forward to seeing you then. And thank you again, Amanda. And take care. Enjoy the rest
Thank
of
you
your
for
day.
attending Pre-Hospital
Yes, thank you
Management
all.
of Paediatric TBI and the Impact of Dealing with Traumatic Paediatric Emergencies, presented by Dr. Amanda Humphries-Ventura and proudly supported by Zoll. Be sure to follow us on social media to keep up to date. Twitter at CAA Australasia, Facebook and LinkedIn, the Council of Ambulance Authorities. Thanks for joining us and have a lovely Christmas and New Year. We look forward to seeing you again in 2023.